Greetings from Sankalp Hospital. This is a case of large cervical fibroid of approx 15 to 18 centimeter. Patient was 45 years old, presented to us with complaint of acute retention of urine. On ultrasound, there was huge cervical fibroid, and on laparoscopy, we could see that the large fibroid was there in the cervix, and the uterus was giving the lantern on the dome appearance. In cervical fibroid, usually the ureters are so close that it seems that they are inserting into the fibroid itself. So in such cases, there is a high chance of thermal injury to bilateral ureters. So in such cases, dissection of ureter is very important so that we can separate them away from the fibroid to avoid injury. And in such cases, taking the uterine at origin is also important, because while taking the uterine with the uterus, in the process of hemostasis, there is a chance we may do thermal damage to the ureter. So initially, we are separating the colon or physiological adhesion of sigmoid we are releasing, and then we are opening the retroperitoneum on the left side. Here we can see the ureter. It is running over the fibroid itself. Always be gentle while dissecting the ureter so that to avoid its vascular supply. We are dissecting the ureter away from the fibroid. Now we are dissecting the bladder away from the uterus. In such big cases, usually patience is the key and meticulous dissection. Dissection should be meticulous and gentle to avoid any inadvertent blood vascular injury that will spoil your field and your mood as well. Now we are cutting the upper pedicle attachments, ovarian ligament, tube and round ligament. Always go slow, step by step. Always keep an eye on the ureter while dissecting the posterior peritoneum as well. Here we are dissecting the uterine artery so that to ligate it at the origin. We can see that the uterine vessels are enlarged. Now we are coagulating the uterine. Always while coagulating the uterine, keep an eye on the ureteric peristalsis. Such big fibroid can make the uterine manipulation a little difficult. Now we are opening the peritoneum on the right side as well. Here, cutting the posterior peritoneum, we are also keeping an eye on the ureter. We can see that the ureter here as well is directly running over the fibroid. We can see that the ureter is pulled up towards the fibroid through the peritoneum. So we are dissecting it away. Here we have dissected the ureter till the tunnel. We can appreciate the uterine here as well. Always clearly dissecting the uterine and separating it from the surrounding tissue is the key while taking it at the origin to avoid any inadvertent injury to the ureter, thermal injury to the ureter, and bleeding as well. Because the peritoneum is the bad conductor of heat, and without dissection, if we'll try to coagulate the uterine at origin, then there is a chance that effective coagulation will not be possible and the uterine may bleed. Here we have injured the uterine vein and then we have managed it. Now we are doing the colpotomy. In such cases, it is always better to start the colpotomy from the back. Never cut the colpotomy from the front side, as the uterus, because of the large cervical fibroid, may fall backwards, and then doing the colpotomy at the posterior side may be little difficult. So here we are proceeding the posterior colpotomy first, posterior and then lateral, and then lastly we will do the anterior colpotomy. Here we are doing the posterior colpotomy first. Lateral, posterior, anterior should be done in the last. Now we are doing the anterior colpotomy. Effective vaginal morcellation is very important, and it requires a lot of patience to remove such huge uterus. Now we are doing the opportunistic salpingostomy as well. And then we have sutured the wall with V-lock suture number 1. Thank you so much for watching.